We're good?
Hello.
Good afternoon, everyone. I'd like to call the special meeting of the Northern Nye County Hospital District Board of Trustees for June 23rd, 2022 to order. Would everybody please join me in the Pledge of Allegiance? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God.
Line unmuted.
There's a terrible noise on the line.
Is that me? Is that good?
Yeah, I was just turning off whatever I saw.
Okay, help it.
Stop. Nancy's on.
Thank you, everyone. Can we confirm who's online?
This is Nancy.
Nancy and Remza.
Hi, Nancy. How are you doing?
Great, thank you. Sorry I can't be there
What about
tonight.
Tom,
I'm
Vallis?
here.
Okay, Remza, Kevin's on? Okay. Hello, Kevin. Okay, so let's start this meeting. You ready?
Yeah.
Okay, item number 2 is general public comment. 3-minute time limit per person. Action will not be taken on matters considered during this period until specifically included on the agenda as an action item. First, do I have anybody with public comment? Nobody? Anybody on calling? Okay. Item 2, approval of the agenda for June 23rd, 2022. So the only thing I can think of is we can delete item 5, emergency items, correct? Yeah. And everything else looks like it'll stand, all one item. So we'll leave the agenda minus the number 5 emergency item stand. Item 4, announcements first.
I do have an announcement. I do have an announcement to the gathering for our clinic providers, EMS providers. We've set the date for August 27th and 28th, and I know that that's a ways out, but it was the best I could do because my July schedule is so crazy. So August 27th and 28th. So before you leave, Stephanie, will you get with me? Because I got some information for you. And I went ahead and scheduled both days as I set that action and the activities. We may not need both days, but that will give us both days of reserve on the convention center.
Okay, that's what.
Yep.
That's what I was going to ask. Where are you going to hold it at?
At the convention center.
Okay.
Yeah.
Main room, buckboard, blue?
No, I asked for the main room. That way we would have enough room.
Okay. All right. Anything else? Jim?
I'm fine for now.
Nancy?
No, sir.
Do you have anything? Any announcements?
No, sir. Can you hear me?
Okay. So I'd like to welcome everyone, and let's move on. I'm not going to make a whole bunch of announcements. Item number 6 is trustees liaison comments. So I'm assuming we've already got this taken care of, correct?
Yep.
Item 7, huh? Oh, Tom? Okay. Item 7, for possible action, discussion and deliberation of various entities looking to provide medical services inside the clinic at 825 South Main Street and any corresponding contracts and or presentations. So the floor is open. Who would like to talk to us and present first?
I have Queenie's first, so.
Queenie?
She's just on top.
Okay.
Hi, Queenie Manuel, Quennie Manuel. We were here the last couple of meetings. I think everyone's familiar with what we're trying to accomplish here. Like I said, we want to collaborate with Marie with what's currently here. And I don't know if you want me to go over at it again, and I'll have Dr. Coca explain it more.
You guys,
Do you want to go over your revised stuff that you submitted for this meeting? The
it's a 2-pager?
2 or 3 pager, whatever it is. Yeah.
Yeah, this is Govind Koka, Govind, last name Koka, Koka. Yes, it's a 3-page document, 2 pages and 1 exhibit, financial forecast. And basically, the thing that we added to it was pretty much a breakdown of what we would need to kind of justify the use of the money. And the first and second page kind of goes into what we would be offering and what we think we could provide out of that location, barring I've only been there once to look and see what's there, and I've not done an inventory of what's available in the location. And then we kind of break it down into what we will be able to offer in the future, based upon once we apply for certain licenses and grants as well too. But the grants is later, but the licensing can only start once we have an official location for the practice. And then we put down our capital requirement of what we would need, and then we put down how we would actually use this money in a generality basis until we get real numbers and we're actually in there.
Okay.
So what grants do you anticipate as a private for-profit corporation you'll be able to apply for?
We're going to apply for the HRSA. Even a private company could actually apply for some of those grants. Even, being in the rural community, there's grants for a private company or nonprofit company.
Because the Rural Health Information Hub has no grants available in the state of Nevada to a private corporation right now. You've researched these fairly in-depthly?
I have. I could even reach out to, a lot of the local community, local government that I could actually ask for those grants.
Okay.
I know HRSA has one, and then there's one national rural company that they actually give out to the rural community. But we need to show that we actually have a facility here. I'm familiar with the building that you guys have at 825 because with Van, when we were here during pandemic, so I know exactly what you have and what kind of licensing you guys need. I've started it previously. When I left, I just handed everything over to Van and his staff, and it fell from there. So there are a lot of available grants.
What kind of licensing do you anticipate that to be?
Number one is the CLIA waived, the X-ray. You guys have the X-ray. I do believe I spoke with Doris already with the Department of Health and Human Services. He's requiring just a transfer of information, and also my medical director, which is Dr. Koka, and all of our staff make sure that they have the licensing that they need.
Right.
And then the radiology, same thing, the Nevada Department of Health, but on the radiology portion of it, they're familiar with the machine. It's just a matter of transferring over the information. And I'm familiar with all the information that's been transferred. And then I do believe, I'm not sure if you guys have it, I know I have a copy of, what do they call it, for radiology. I know it's the CMS, but for me to transfer the ownership over or to the clinic over, I need to register with that certificate from the radiology place who sold the company to the county.
Is that the only licensing and accreditation you anticipate?
Some other ones too for rural community. And then eventually with the CLIA waived, we want to go to the moderate because it's needed over here, especially for CBC. So there's many things that can be, when we remodeled the building over at 825 South Main Street. The way I wanted that built on the lab to where it's open on both sides, and it's big enough to have a moderate, even complex. It could supply, it could carry that. Of course, once we do the complex side of it, you would need a lab tech, you would need a pathologist to do that. So, it added some other expenses. So as of right now, what you have there, all the certified the approved, CMS approved for CLIA waived, you have the capability of performing them there. And I know you guys have the PCR machine as well. When I was there, when Dr. Koka and I was there last week, I didn't see it, but I could be mistaken because there's so many other stuff there. But you guys do have the PCR machine. Okay, you could also be a POD. You have the equipment, necessary equipment to be a POD.
Okay.
So, and I understand that you operate 7 clinics in Las Vegas.
Yes.
And
surgery centers.
Yeah, well, 7 clinics is what I heard the last week. And you guys formed those in the last 9 days?
No.
I didn't think so, because your Secretary of State says your company didn't exist before 9 days ago.
No. Those clinics are Dr. Coco. We've had those clinic.
Open the first one. I opened the first one in 2004, November 1st. And we've opened up and marched them across Las Vegas, and for a while we were in Pahrump as well too. The last clinic we opened up, assuming that if we don't count this one since we don't have it open, was approximately 2 years ago.
So are you Health Solutions LLC or PGM Holding and Trust?
The company that would be the 7 clinics would be Gov and Coca, DOPC, which is me.
So who are those other 2 corporations that manage this particular corporation that we're going to be entering into a contract with?
Health Solutions is me, 100% owned by me. It's just a company I made to work out here in Tonopah. And the other one is Queenie's company.
The other one is my company.
Okay.
It's a trust. It's not, yeah. And then there's also one clinic. It's First Choice Urgent Care that we're building in North Las Vegas. It is 6,000 square foot right now. Because of construction, we're actually operating on half of the building, and the other half is being constructed still. It's been like 6 months, and it's ridiculous. We're also planning on, we have the medical van facility. We're planning on participating this Saturday to provide you with the medical care that you need. We will have the medical van that we have over here. I say van. It's like a size of a U-Haul that it has a waiting room. It's an RV that we could provide and help out for the Flag Day that you guys have on Saturday.
Okay, great. So in your proposal, you're talking about providing us with, is it a PA?
Correct. It's a PA that used to work here in town, and I do believe he has a pretty good reputation here in town.
Okay, and then your hours, you're planning on staying open from 9 a.m. to 7 p.m. Monday through Friday?
Correct, and he will stay inside the building, so if after hours he's needed, he's willing to be on call for an emergency. And we did that previously too during pandemic. There was one particular that I could remember. It was Canyella and my other provider that they actually saved that person's life. They called the emergency and flew him out, and he was at UMC right away. So it makes a big difference having that provider there 5 days a week. And the weekends, if it's needed, we'll do it, you know. And as we add more hours, and I'm sure the providers would want to get paid for that. So we'll start it Monday to Friday, 9 a.m. to 7 p.m. And if it needs to be extended, like I said, the provider's there, so he's willing to be there.
Which provider was it that was here previously?
Brent Kunstler. He left because of the disagreement that they have with Van.
I believe he was the one that was coming from Utah, was he not?
He's from Utah.
Yeah, and he was staying over at Hawthorne, and he was just looking to cut some time off his commute.
He was at Hawthorne, yeah.
Yeah.
Yep, he was at the hospital in Hawthorne. I guess it makes a big difference, with these providers who they work with.
Patty? Any questions? No?
Did we purchase a iStat machine for that clinic?
I do believe you do.
That's what
You
I
have
thought,
the
and I
iStat.
did not see it when I looked through, so I was curious. And I see it in your listed CLIA waived.
Yeah, you have all the equipment for the CLIA waive. That's why when I submitted previously the whole list that are approved with CMS with the CLIA waive, because you can do them there. And then as soon as maybe a month or 2 months after that we're there, I want to apply for the moderate. It's just a matter of, having the right staff and the equipment. And like Dr. Coca mentioned, that CBC is very important.
It is.
Anything else for the initial? Go ahead.
Hello? Hello?
Yes, go ahead. Who's this?
Can you hear me? This is Tom.
Go ahead, Tom. This is
Tom
Don. We got
Ballas.
you loud and clear.
Okay, so I have a question in terms of if you're having a PA, who's going to be the supervising physician?
Hi, Hi, this is Govind Koka again. It'll be either myself or our other physician we're going to have here, depending upon state regulations in terms of how many PAs we're allowed to have. I have an opening for one more, and I don't know the other doctor how many they have, and I don't know how many PAs you're going to have here. So me officially, I can only supervise one more unless I go back to the state and ask for a waiver because because we'd be out in a rural community. We had that before when we were Pahrump. We had it extended from 3 to 5. So as of right now,
so I
I'm
was
going to
just
do myself
making sure
or the doctor.
Just making sure that somebody's thinking about that. And also, are you an MD or a DO?
I'm a DO.
So is your PA licensed by the medical board? I mean, it's kind of tricky when you get to cross-pollinizing for supervision. I'm just making sure that we have that in mind. I'm not asking you to explain it now. I'm just making sure that that's on the radar.
Yeah, we actually have another provider. He's an MD. And our PA, Brent Kunstler, he has the DO. He's also a nurse practitioner, by the way. He's a PA and a nurse practitioner.
But like I said, you don't have to explain it now. I just wanted it to be on the radar. I know you'll take care of it. I just wanted to make sure people are thinking about it.
Yes, sir. Thank you.
Anything else for Queenie and Doc?
So as you open this up, where would you get your support staff, your phlebotomists, your front office, your back office? Where would those people come from?
My plan and my goal to actually hire the staff that we have in Las Vegas, bring them here temporarily and train the staff or the people that are here that are already licensed, because a lot of our staff, like X-ray tech, our X-ray tech can do a blood draw. They're also an MA. She's actually going through nursing school right now. She's willing to come out here, and she was your X-ray tech previously here. She's willing to train. So if you have any someone here in the community that are trainable or somewhat willing to learn, or we can train them, we'll be more than happy to actually hire them on and do training in the meantime. So I don't know how long it's going to take for them to learn from X-ray to the phlebotomist or, the MA, they could do it. I'm also planning on bringing an EMT that could actually help out with our provider.
Would you ultimately want to recruit locally for long-term?
Yes.
Okay.
So as I would say 1 month, I'm willing to steal our staff that we have in Las Vegas, bring them over here, train them for about a month or two, or depending on, like I said, how fast they could learn how to do X-ray and all that. Licensing wise, I think in the state of Nevada, just as long as they're under a medical provider, like with Dr. Koka, they could actually perform the X-rays. The reads, they will be done by Pueblo Medical out of Las Vegas, all the readings that we have. And then eventually, I could reach out to Toro in Las Vegas, and they've mentioned this before, where we could actually bring their mammo machine over here. And then I also want to go to I know back then when it was COVID, I went to Gabs. I was told you can't go there. Someone reached out to me, and when I got there, they expressed their gratitude on how thankful they are that I was actually there to help them out, because no one has reached out to any kind of medical. So my goal is to actually go to the small community at least once a month, or whatever the need.
And would you use that van to do that?
I can. Mm-hmm. I can. Right now, the generator is not working, so I need to plug it on the receptacle for it to work. Like on Saturday, I was asking Don if there's a receptacle for me to put on. But yes.
So, okay, I know one of our problems up here in the small community is immunizations. We lost our health nurse, so we don't have a health nurse right now. So there's no place to get COVID vaccines or flu shots or anything. Are you guys set up to do that?
Yes, we will need to get a different licensing for this location. Our staff are already certified with WebIZ. It's just a matter of the location having it certified with WebIZ. That's why I mentioned the POD. I'm also planning on asking the Department of Health to actually give us the vaccine for COVID. All the vaccine, even kids' vaccination, immunizations.
Okay.
With your mobile setup, what are the capabilities inside of it? Is it just a exam room?
We have an EKG machine over there. We can put whatever we want to put in there. Right now, we're utilizing it in Las Vegas with one of our locations because, like I said, we're still doing construction with First Choice Urgent Care that we have. So we're using it. We have an EKG machine over there. We could do UA, some lab. It has a bathroom. It's a full-on, just like an exam room with a small lab.
Okay.
Anything else?
Nothing from me.
Okay, thank you. Relax. We might have to call you up and get you to answer other questions.
Can I make one more comment?
Absolutely.
So one of the things that we've done over the last 10 years is teach students, PAs, DO students from Toro. And so there are some requirements to rural medicine. I've never had a location where I could actually have some of those students come out. And one of the nice things would be if they actually came out here, fell in love with the community, and wanted to stay here long term. Don't know if that would ever happen, but having a place here would be a place I could bring some of those prospective students out. And noticing that there's some housing in there, that would be a big thing for the school because, they don't pay for housing for kids, or students rather. I guess they're kids to me now, but students to come out here and learn. And so having that would be a nice thing. And you never know, they might find someone who would want to stay here long term. Because according to the study that we looked at last week, we're going to need 6.4 people, primary care doctors here in town, and in 5 years, 9 point something. I think 9.7 they said, which is a lot to get to come out here.
All right. Okay, thank you. You're up.
Hello, everyone. Devin Eisma, D-E-V-O-N-E-I-S-M-A. I'm a nurse here in Nevada and the CEO of Optimum Medicine. Thank you so much for having me. We're excited to be here. So this is kind of our vision for the clinic.
Would you bring
yeah, if you don't mind. Oh, I clicked. It's up. It's there.
It's always technology.
Oh, yes. I don't know what I have to do.
It's like our Achilles heel here every once in a while.
Sure. So a little bit of background about me. I went to CSN in Las Vegas, graduated in 2006, have worked in emergency department, ICU, transport, kind of a variety of different things, managed UMC's adult emergency department for a couple of years, and then wanted to get some critical care experience in the trauma ICU. Went there. From there, I got hired at Mercier as a regional clinical manager, and helped to supervise Nevada and Arizona and California, all the clinicians. And somewhere in there kind of decided that I didn't want to keep climbing in other companies and created our own. So we were founded about 5 years ago, all clinician-owned, nurses, medics. We emptied out 401ks and savings accounts and put money together and said, how hard could it be? And it's really hard. But 5 years later, we're alive and kicking and getting to do the things that we really want to do. So this is absolutely included. So kind of my thought process on Tonopah, just so that everyone knows, I used to work for Flying ICU. I worked many shifts out here when the airplane was here and the hospital was in service, and got to know the community and its unique complexities and what they needed. And I know exactly what this is, which is, I hope gives hopefully a little background on what I'm able to kind of think about and consider when we are putting forward a plan of what we think will work. So what we currently know, the providers, Marie Peterson, of course, busy, working out of 3 exam rooms, seeing tons of patients, right, doing a fantastic job, and just busy, up to our eyeballs busy. Remza with community paramedic, working with the volunteer program, right? Nye County Ambulance Service, Stephanie and others, helping to make that happen. And then the Tonopah Clinic in italics, right? The hope is for that to sort of be the other piece of the puzzle. Kind of the way that I see the current operations working, we have each of the entities represented. You get some good overlap, I think, between REMSA and Nye County Ambulance Service, right? They're obviously routinely working together, helping each other solve logistical problems. You got primary care and then the clinic kind of sort of separate, right? And the patient is in the middle, and their job is to sort of bring all of that together. When I'm not feeling good, or when my grandmother's not feeling good, she doesn't want to be that go-between to try to be the one that brings all of that together. She wants to go somewhere and seek care, not be her own case manager. And so I think in communities like this, it is really important that we find out how we can bring those things together in alignment. And so the things that we all look for in healthcare, reliability, right? We want to trust the doctor that we're seeing or the provider that we're seeing. We want it to be affordable. We only go to an out-of-network provider once, and then we realize we'll never make that mistake again, right? And then we want quality. We want to trust, again, what we are being told, that we are getting the right care, the right treatment, whatever it is that we need for our particular injury or illness. And that's the same. It doesn't matter if you live in Las Vegas or New York or Tonopah. It's the same. You want those same three things, I think, from healthcare. So how is this achieved? In large areas, people go to who they know. They go to providers that their friends refer them to. They go to who they are in network with. They go to who is the nicest front desk. Or in the case of EMS, they go to which hospital has the best break room that you're going to get your best snacks from. We get to make those choices, and the market helps to dictate itself based on contracts and payers and things. But here, how do we do that? And that's harder because we don't have the volume, we don't have the people, the ability to have 5 different hospitals and to have 5 different urgent cares, 5 different ambulance services. It just doesn't work. And so I think the onus on anybody who operates out here is to find out how do we bring those things together to allow the patient to be squarely in the middle with overlap on all sides, and so that each entity is talking to each other and that the patient doesn't have to bridge that gap. They get to be in the middle receiving care, and that's the important thing. Going to school as a nurse, this was the whole point, right? And the challenge still is, how do I take care of patients like I want my mom to be taken care of? And I like my mom. So about us, like I said, founded back in 2017, a group of clinicians, nurses, nurse practitioners, paramedics, with one goal: to make things better. We had worked for other companies, other facilities, other areas, and knew what they did right and knew what they did not do right, what things we would change. And we said, again, how hard can it be? We've worked in rural Nevada before. We've served in Elko, Winnemucca, Ely, Pahrump. Like I mentioned, I personally have worked out here in Tonopah. And we are patient-centered, solutions-focused, and creativity-based. Our onus starts and stops with the patient. That's the whole thing. It's not a balance sheet. It's not a money-making entity. Sure, we have to pay our bills. We have to be able to pay our people. But that is not the number one reason why we started this. It's to take care of people and to make Nevada better. So our current operations include fixed-wing air ambulance that's based in North Las Vegas Airport. It's a King Air 100, very similar to what Flying ICU had here. And we are in service now, have been for almost 6 months. Pilots on staff, nurses, paramedics, et cetera, can handle sick, death and destruction ECMO all the way down to easy-peasy stuff. And that has been something that we've been developing again over about the last 6 months. So it's exciting for it to be in service and operational. We offer ground ambulance services currently in Las Vegas, surrounding areas, the VA, O'Callahan, Pahrump, Boulder City, et cetera. And that has all of our ambulances are staffed at the critical care level, so nurses or critical care paramedics. And we can handle the same stuff that the airplane can handle, but just with 4 wheels. And kind of like Queenie mentioned, the mobile clinic, that kind of gives you a picture. I bet yours is very, very similar. So we kind of saw this just like others have, that this is a way that we can extend healthcare and bring healthcare out to the communities where it's needed. So ours is 2 exam rooms, exam tables just like you'd see in a doctor's office. One of them has a wheelchair lift, so that patients that are not able to roll up the stairs on their own, we can get them in. And though we possess 2 of those, we got ahead of the pandemic, so we ordered them ahead of time and were able to get them in. They're functional. Portable X-ray, ultrasound, lab are all installed. And so we're able to go on site and be able to deliver that kind of care. We do that for a variety of things, outreach events. We do event medicine. So if you go to some big concerts or football games or things like that, we're able to bring that clinic on site. And so then if somebody turns an ankle, we can shoot an X-ray, find out if they need to be transported or not, or if they can go back and have fun for the 3rd quarter or whatever it is. So from what I know, what does Tonopah need from a clinic? urgent care services. That's the big thing, right? Including extended hours. And I think the way that you accomplish that in a place like here is to utilize experienced emergency care providers. We need diagnostics and then procedures, right? We need to be able to suture wounds and reduce joints and foreign body removals and things like that. Things that we normally see in the ER, just less frequent with less resources here, is how we need to accomplish that. Primary care services for spillover from Marie or patients that want to come in and be seen, routine checkups, and then, of course, long-term disease and medication management. We also need some occupational health, right? The hearing tests, the fit tests, things that local employers need to be able to send their employees so they don't have to go to Reno or Hawthorne or Vegas or wherever they need to go. They can get that done right here. And the great thing about that is that we have the facility is there. You've already created it. You've remodeled it. All the tools are there. That helps to offset cost of that building being open. And in my opinion, that's the number one reason. Plus, it is convenient for the people that live and work here. They're not having to always travel out of town to get that stuff done. I think that the clinic needs to be integrated with transport services. Like I mentioned, we offer fixed wing and ground ambulance transportation, not to usurp anything or to take anything over, but to be able to provide additional services so that those that are currently providing service don't get overextended, overrun, overwhelmed. That's something that we can help with. And then outreach. Showing up and putting a name on a building and saying, hey, we're open and expecting to have 50 patients on the first day, it doesn't work that way. It's Queenie knows, right? You don't just open it up and say, hey, we're here, we're good, we expect to be busy. You have to earn that, and people have to become comfortable with you, and they have to understand what you're trying to do and that you're on their side. I think that you can fill the needs of employers and other referring entities, right? So they naturally start to send traffic to you. And then things like building a relationship with community members, provider meet and greets, having open houses, Q&A sessions, things like that. So that the first introduction they have is not when they're having some horribly embarrassing thing that they don't want to talk about, but they get to talk with someone at the coffee shop or at a meet and greet dinner or something like that, so that they build a relationship and there's a rapport there, instead of showing up and saying, hey, what's your insurance card? I hate that. I don't like that at the doctor's office. They don't ask what my name is. They say, let me have your insurance card and your driver's license or whatever. So for our proposal, what do we think, how do we make this work? We would like to have an emergency service provider, a PA, NP, or a physician in clinic. We're proposing very similar hours, Monday through Friday, 9 to 7. Staff would remain here overnight, so available for on-call. Sounds like that is exactly the right kind of model. We'd also utilize critical care ambulance and flight personnel in clinic, so that allows us to handle sick stuff. We're used to airways and drips and a bunch of other crazy things that we manage on our own when we're in the dark and traveling from one place to another. So managing it here, I think, would be right up our alley. And then a front desk or a tech. As mentioned, most of the things that are able to be carried out in a physician's office can be done by those personnel. You don't need a ton of extra. And then on-call services, like I mentioned, that would all be routed through our dispatch center. So we provide 24-hour dispatch services to our airplanes and ground ambulances. All the dispatchers are emergency medical dispatcher trained. So if they got some call that needed to go through the 911 system, they would dump it immediately. And then so that somebody's not on our doorstep and they need care and they're not receiving it, we would be able to accommodate that. Lab testing, moderate complexity, I think, is a must. We have that application already in for our ambulances and our airplanes. The testing that we're wanting to move to requires moderate complexity. So as Queenie mentioned, we would need to add another location. That's a rule. But once the infrastructure is there, it's fairly easy to duplicate because you got your processes down. For radiology, X-ray, and ultrasound, the CAT scan, it sounds like, may or may not be operational. We got to sort that out if it's able to be used. But we would absolutely utilize it if we could. And then just let you know on what the reality is of what will work and what won't work, and then make a decision collectively if it makes sense to expand to that level of service. As far as procedures go, laceration repairs, like we mentioned, foreign body removals, etc. That's what people need: Foley catheter placement, chest tube placement, that kind of stuff. And then EMS procedures. So like I mentioned, those guys are used to handling the sickest of the sick. They can airways, RSI, and then headed to the airport for transfer out. That could all be managed in-house. And so that's a great way for us to be able to offset cost, is that once those providers step outside of the clinic, now they're our employees, right? They're no longer staffing the clinic. So immediately their clock stops, and now we're not trying to utilize those resources. Fantastic way to double up. So we get the right level of care in the right spot and at the right price. And then we offer in-house billing department. We handle that ourselves. We feel very strongly about what letters are sent to people and how they're sent. To date, we've never sent a patient to collections, and that's something that we believe very strongly in. Another interesting thing is on the transport side, we work with a nonprofit called the Southern Nevada EMS Consortium. We hope to start it, and we are able to provide transport services to any Nye County resident for no copay. So if we fly people, they don't ever get a bill from us. We bill their insurance, and we call it a day. We're a Medicaid, Medicare provider, of course, and then our in network with most insurances. I'm sure there's a few outliers around. So for initial funding, we have to have the supplemental funding. That's the way that we get this thing started, right? That's how it works. We immediately start to bill commercial insurance, Medicare, Medicaid, and then we have a kind of a different take. I think that the grant route is going to be a little rough. I think there may be something out there, but I think it's going to be tough. There's an entity that we work with. It's a federally qualified healthcare center, and what those are is they get kind of special treatment in rural or underserved areas, and they allow Medicaid or the federal government to be billed with patients that cannot afford it, like on a sliding fee scale, and they offer enhanced reimbursement is the way they refer to it, enhanced fees. And so that allows us to, again, take care of every patient that walks in the door. We're not worried about whether they can cover the cost or not. And we're able to get enhanced reimbursement so that we're not expecting that somebody else picks up that tab. We can handle that on our own. As far as planning, work with the existing operators and figure out how do we maximize this joint effort? How do we not duplicate resources or pull in different directions? We would look to go for rural health clinic and or critical access hospital designation as the time comes. I see this as growing, not as going backwards, and we would love to help to facilitate that growth. That allows us to receive ambulance traffic, and then we get increased reimbursement for both of those options. And then partner with Nevada-based specialists. So I think that we can bring specialists here on an as-needed basis, just like Queenie mentioned, weekly, monthly, yearly, whatever it happens to be. I think they'll come up on their own. I think that there's an ability to make that happen because they want referrals. And they may not be Vegas. It could be Reno or some other place that has these specialists. I think you could bring them up one day a week, one day a month as the time went, because they want, especially on the transport side, they want patients that they can admit, that they can see elsewhere, not just coming up once a month, right? That's not going to make or break them. And so I think we can do that without having any kind of cost incurred. I think that's my plan. Any questions, comments, thoughts?
When we start talking about the mobile units, I think that's really important because while we do a lot of talking about Tonopah is not the entire piece of our district. We represent the total northern Nye County, so that is GABS, that's Round Mountain. And I know Round Mountain Gold has their clinic, but Round Mountain Gold's clinic only sees Round Mountain Gold's people. And so those mobile units in places like GABS or Current Duckwater, that could be so beneficial because then it not only has us covered here in Tonopah, which of course is a bigger population than they are, but it also gives our full taxing district the benefit of the taxes that they're paying.
And that's a great example of streamlining the system, right? So if we work with Marie or the volunteers or REMS and we say, hey, Monday is our Round Mountain Day or is our Duckwater Day or whatever, we're going to be out. In the meantime, this is what we'll come back this. If you need something, let us know. That's a great way to, like you said, this is not just Tonopah. There's a lot of other places that are teeny tiny, but that doesn't mean that they don't need the same quality of care. We can't build level 1 trauma centers everywhere, but we can still bring them the services that I think make sense for them.
Well, and in fact, if you're in GABS, you're paying the same amount of hospital district tax that you are as you pay in Tonopah.
Right.
So they're not getting their money's worth.
Their share, right? Right. And someone asked about vaccines. We are a COVID vaccine provider. WebIZ, exactly as Queenie mentioned. We order our own vaccine, we store it, we have our own PIN numbers. We currently operate a large vaccine program for the state of Nevada. And so we go all over. We've been to GABS, we've been to all everywhere. Anywhere town you can think of on the map, we've probably been there. And this is something that we've been doing for about the last 8 months. And I anticipate would continue, both flu and COVID vaccine currently. Expanding to others is very simple. It just boils down to what we need exactly and then funding.
So I'm assuming that when you're certified, it's for the entire state, not county by county.
Correct. Certified for the entire state. There are a couple of exceptions on the ambulance side that we cannot operate, and that's Clark County and Washoe County. They have special designations because of their population limits.
Okay. I'm thinking about our partners, Esmeralda County, which has no health care whatsoever.
Yes.
And granted, Goldfield is small, but we have Dyer, we have Fish Lake Valley, we have Silver Peak. So
yeah, I think taking that core of operations, right, getting that right, nailing it, saying we can set it and forget it. We know for a fact we can do these things: urgent care, occupational health, primary care, right? That if we nail those, we get creative, and we're about as creative as you can imagine. And if there's some weird, crazy thing, hey, we want to try this, I want to hear it, because I'll probably try it, because we love to do fun stuff, and we ask for clinicians to do all kinds of crazy stuff. We have a crew right now that's flying from Hawaii to Tennessee, a girl that was in a helicopter crash. And this is what we do. This is normal for us. So if I say, hey, I want you to go hang out at a clinic and see urgent care patients in GABS, they're going to be like, rad, where do I go? They're going to love it.
I thought I heard Nancy with something. I just wanted to make sure she was.
Nancy?
I heard the thing on mute, so.
I guess probably saying, I hate to say it, but I don't hate to say it, but it's amen. Everything he said sounds really up my sleeve here. What I would like to see come to Tonopah and all of Northern Nye County, as we've already mentioned it, but the base is there in Tonopah, ready to go. And I wanted to ask you, how soon could you come to our clinic in Tonopah?
I think a reasonable start date is August the 1st. I think that's being real. There's a chance that it could be sooner, but I think licensure, it'll depend on a couple of things. Any entity that comes here is going to have to go through some licensing red tape to be set. I may ask a favor. We have got great relationships at the state if we decide that we're going to go in this direction. I may need someone to call and just say, hey, help me out. But I think August 1st is a very comfortable timeline.
All right, so let's talk money, because there's no dollar amount at all in your presentation, and that's really...
1 second. Tom, do you have any questions for the second group? He's not? He's gone? Disregard.
Let me grab a couple questions here real quick, just because. We talked about the capabilities of your mobile truck. You did say you've got X-rays installed.
Yeah.
You are able to, I assume in some way, those are very high broadband or broad files and stuff like that. You do have a way to transmit those wirelessly.
Yeah, so all of our vehicles that our company utilizes have cradle points, just like in ambulances for tracking. They've got some beefed up kind of Wi-Fi capability with antennas. In fact, I stepped on one when we were driving up here. I said, who didn't fold this? But yes, all of that is included. As long as there is cell data reception, then we're able to do that. The great thing with utilizing emergency providers and ER-trained, centric providers is performing a wet read on an X-ray is very normal to them. So we don't always have to get every single one looked at by a radiologist. We get to eyeball them and then send them off. And that's why our focus is to go the ER kind of heavy route, but on this light kind of platform, because the need doesn't change. It's just the volume and how many patients we have. That's what changes.
You mentioned staffing. You do have a medical director I'm assuming, I know it's required by the state, but.
We do. We have a couple that are involved. Anesthesia critical care certified, along with CCAT trained. He was military. He's been a great fit for us. And then several board certified ER docs that are affiliated that work with us pretty regularly.
And listing in your staff, you have a lot of emergency providers, as you said. They are what I'm essentially boiling down to is like a cross-trained, dual function, even probably triple function type of personality. These are, I assume, cost-saving measures to drastically reduce your cost.
Yes. The goal is providing that highest level of care on a dollar amount that is reasonable, and the way that you do that is by duplication, right? They have to be multi-purpose, multi-function, dual role, triple role, as you said. Otherwise, you won't ever make it, as far as I know. And so that's absolutely our focus.
Any critical, I know you were talking about your lab testing capabilities, and you were already starting to work on the moderate complexity ones for your transport program. Critical one, which ones are we talking about that you're working on currently?
Yeah, so the EPOC, which is a blood gas and chemistry machine that can handle like hemoglobin, hematocrit, things like that. That's a moderately complex device. There is the Quidel triage is what it's called. That's actually waived, so that we could get going immediately. That does D-dimers and BMP. It evaluates for blood clots and for blood clots mainly, and for heart function if your lungs have extra fluid in them. And then the third one is the Piccolo, which I saw when we toured the facility, and that does a great range of chemistries, liver function, renal stuff, a lot, triglyceride. You can do all kinds of cool stuff on the Piccolo.
I don't remember off the top of my head where it falls, and I could probably sit here and stare at the massive list that Queenie gave us and figure out exactly where it falls. The troponin. That falls somewhere within there.
Yeah, that was in the Quidel, the triage,
okay.
And that's actually waived, that particular device. So stat troponin, which is a great differentiator for acute heart attack, great differentiator.
And you were looking for the federally qualified healthcare center to provide you with the scale and the rural health clinic designation for the ambulance traffic at some point. You said there was increased benefits to your reimbursement, enhanced reimbursement.
Yeah. So on both fronts, the rural healthcare center has enhanced reimbursement. They automatically qualify for some of the rural, underserved, population metrics that are required to be able to have increased billing, increased receipt from doing the same service. And then federally healthcare is the same exact idea, where if the patient can't afford to pay, or maybe they're a Medicaid patient, Medicaid is not a great payer. Everybody in this room probably knows that. And this helps to offset that. So that way you can offer that same level of service, and we're not drowning, to see those patients. We get to set it and forget it and just do what we are good at, which is taking care of people how we want to be taken care of.
Is there any detriments to you being able to accept ambulances with those? I know it's required by CMS or at least most companies, that they get reimbursed. So CMS allows you to do that. Is there any roadblocks that you foresee for being able to receive the ambulances under that?
I don't think so. Really what it's going to boil down to is local providers and everybody being on the same page. If everyone is on the same page and we have the same message as to what makes sense and why, we'll be fine. If we are pulling in 5 different directions, we're going to have problems.
So as I had a conversation with the state the other day, and with Kevin, our REMSA vice president, it comes down to basically that the medical directors of the individual ambulance services have to agree and develop that desire to want their patients to be transported to that.
Yeah, essentially the responsibility is that the ambulance service has to be confident that that clinic, that place, can provide the care that that patient needs. So if you are having a heart attack and they bring you to a standard physician's office, you're not going to do so hot, right? That's not the place for you to go. But if you have a place to go that can provide proper care and has the ability to take care of that sick patient, and let's face it, the patients that are sick here need to be stabilized and transported. I would love for that to not be the case, but that's the case for now. And so being able to get that right is what is the vital function of that clinic. We randomly we're out in Beatty or in Amargosa, I'm sorry, and rode along with their fire chief, and they have a very similar non-transporting scenario. And we rode out. There was a chest pain call that came in out of mine, and we said, Owen and I, in fact, were both on it, and we said, well, what do you do? And he said, well, we wait. I said, well, where's your stuff? And he's like, well, this is it. And I'm like, holy cow. Like, you get unfortunately, the guy looked all right. And I was like, he's probably okay, but we don't have any of our stuff. And so just thinking about what that is, 45 minutes, an hour outside of metropolitan Las Vegas is crazy to me. So how do we bridge that gap? That's the challenge. And I think this is a component of that.
So I can't remember off the top of my head RIMS's medical directors that would have to agree. Dr. Malone out of Las Vegas, I think he works over at the test site now, is the Nye County director. You're familiar with him?
Yeah, we're very familiar with Dr. Malone. He understands what we're doing. He gets it. I can't speak for him, but I would feel pretty comfortable that we'd be able to work with him to come up with something that made sense.
You have a freestanding relationship.
Very much so.
Okay.
He trusts that we would take care of people in the way that they deserve to be taken care of.
Okay, you may go ahead now. Patty?
The money.
The money.
The money.
I think that initial, just like Queenie mentioned in her presentation, I think the initial estimate of about $70,000 is probably correct to get started. Our goal is to be self-sufficient. That's our goal. How long does that take? I don't know. I'll be very honest. We'll be very straightforward, very direct with what we are going to deliver, and we will make everything that we say that we are going to do, we will do. I've worked plenty of shifts in places that are my wife would rather that I wasn't on holidays and whatever else, because I possess a nursing license and can go take care of people. And so if we tell you that we're going to do it, we're going to do it. If we tell you that we don't know, it's because we legitimately don't know, and there's a lot of variables. I think if we get the right kind of buy-in, that can move along quickly. I think if we do not, then it's going to be a struggle. And we'll be very honest with that, with what we're doing and why. We're straightforward. I'm a nurse, right? I didn't know what a balance sheet was or a profit and loss was when I started my business. I didn't know what a cash flow was. I mean, our finance had to teach us that. And so we're very transparent with what we do and how we do it.
And if I'm understanding your discussion right, the critical patients that either happen to walk in or maybe stop by the clinic via some other means that you transport out, that's going to be another service line that's going to reduce the amount of money that you're going to need.
Exactly. That's precisely it. So once that staff, again, steps outside of the clinic, now they are off the clinic staff. That's now our staff. And the great thing is, more importantly than the money aspect of it, is that patient's care is now coordinated among entities. And so people know what the plan is and what we're going to do to get them to where they need to go, because that's what really, really matters. Obviously, we got to be able to fund it. There's no two ways around that. But the reason for the funding, understanding the value of the line item is what I like to say. I get why it matters to spend money on that.
Right. I just wanted to, just that you had multiple service line or multiple cash flow service lines that is going to help to
Yeah, only to a certain degree, because the minute those folks step out of that facility, while they are not a money drain, they're also not a money bringer inner, because that then becomes their employee and their billable and their money. So that's a difference in just operations.
To be clear, what would be left at the clinic would be a provider, so a nurse practitioner, a PA, or a physician, and a tech. So they would be completely capable of taking care of patients, of essentially anything that walks through the door. There would be no reduction in what their capability was. Now, if 30 people showed up and all sat in the lobby at once, they'd be a little slow. But if we have 4 people and 30 people show up at once, it's going to be a little slow. So there'd be no disruption in service to the clinic.
Yes, but I think Tim is thinking that then it changes the billable for that transport mile, and while it does, it also changes who's getting those dollars. It's just the way that would operate, not good or bad, but it would again, be a money drain, but not a money bringer inner.
Yeah.
Wouldn't it be our money?
Sort of like the current services, right? The patients that are flown out now, the money goes to whatever service happens to fly them. So it'd be the same, except this provider would happen to be in Tonopah bringing service to northern Nye County.
Seems like there was something else in my head, and I've forgotten it now, so.
So if you were forecasting the ability to stand alone, and this really is a question for both groups, what would you forecast that? And I know forecasting can be really crazy because I do understand the business, but what would be your goal of independence? At what point? I mean, I don't know that you'll ever not totally need our tax dollars, but where would that start to roll down?
Yeah, I think that REMSA has kind of a good idea. I think that the setup where they bill at cost plus a margin that everyone can live with, I think that makes sense. That's sustainable. That's something that's easy to articulate. It's easy to see on paper, and it's something that everyone, again, can live with. It incentivizes the provider to be there and to do a good job and do what they need to do, and it also incentivizes the hospital district to be supportive so that way they are able to continue to provide those services. So that's kind of how I would look at it. As our billing goes up and our patient revenue goes up, then that would immediately start to come down. And we'd be very transparent. Hey, this is what we're doing. This is what we're doing.
Well, and you do understand that has not been our experience. So that with some of us will definitely be questioning this like to the cows come home. Because really, ultimately, the goal would be absolute independence, to be honest with you. In no other realm are you going to get a fully operational place to hold your business. Like, I have my own business. Nobody opened the doors and said, here's all your equipment, go do it.
Yeah.
Okay, that doesn't happen in any other industry. And so that independence and head in that direction is something that is a goal, because at the end of the day, we also have this hospital concept that we want to go forward. Yeah. And quite frankly, we're not going to be able to afford to have our hands in all of those little pie with everybody with their hand out saying, give me money, or we're going to have to close our doors. So that's why it's important to kind of have an idea of what that independence looks like in your concept.
And the questioning does not hurt my feelings. If I lived here, I would ask the same exact questions. And if it was my family and if it was my choice, I would ask the same thing. So it does not offend me.
Oh.
You were brought to us by Sarah Allen a few years ago, who is the queen questioner for some of us. So I assume she's asked you all these questions at least 100 times already, as it is.
1,000 times.
I know that we have an issue around ambulance staffing from time to time, especially because calls do pile up. Sometimes 2 or 3 at a time. You having an ambulance there, is this something that you're willing to or able to utilize in a backup fashion to the current operations to, make them not have to drive 90 miles an hour back from Hawthorne, lights and sirens?
Yeah. Only 80. That's where the governor kicks in. 100% yes. Again, as long as we're all on the same page and everybody knows what the plan is and why we're doing it, 100% yes.
Well, and while we're talking about those volunteers, again, a question for both groups is, how do you see your role in their education? Education for these folks can be what I've always termed as inbred. So if I'm teaching you and I'm the smartest person in the room and that's all you get, well, then we're all in big trouble because I'm not necessarily the smartest person, right? So when we have these, our rural volunteer folks, oftentimes that is what happened. They have a hard time bringing in those higher level providers for their educational courses. So to both of you, what do you see your role in that arena?
Yeah, we've actually been up to help to sign off the AEMTs when they were done with school to do their skills. That's something that we do automatically with our
as part
employees.
of their testing team or their teaching team?
As part of their testing team, and so we do that already with our employees, and then our doors are open. Come and hang out. Come start IVs on people and practice and learn. And we don't shy away from that. there's not a territorial component to how we operate, because if we are helping, let's say that there's some crazy thing that happens and we're out helping and we've taught the volunteers something they may not have gotten from somebody else, and they do that for that particular patient, then we've won and we've been successful. So that's sort of inherent in how we operate, and we're happy to include them in anything they want to learn, basically. And I'm not the smartest person in the room either, so we find the people that are.
Do you already, as an ambulance service, you already have a role in education as it is? Do you have monthly continuing education classes and things like that that could be brought up here every once in a while, or on a schedule or something like that already?
We're a training center, so that's exactly the term. All AHA classes we teach, all the pre-hospital trauma stuff, NRP and stable for babies, and then any CE that we can dream up, we can do. So one of the recent things that we did was add maternal fetal monitoring for our longer transports, where we need to know how mom's contracting and what's going on, how baby's heart rate is. And so we brought in a labor and delivery room nurse and worked with her medical director to be able to develop a PowerPoint. We're able to issue CEs for that, and now that's something that have everybody hands-on practice. How does this go? What does this mean? Add it to our protocols, and then we're able to provide that line of service. So yes, we're very well equipped to be able to issue continuing education that matters, that's relevant, that is pertinent.
Queenie, did you want to have an opportunity to answer some of that?
We got like 2 or 3 questions in, and
I know it, and I want to make sure you guys have the opportunity to answer those questions as well.
I'll answer the education one. This is Govind Koka, Govindkoka. We currently have at the clinics, we have DO students, we have MD students, we have nurse practitioners, PA students, MAs that rotate through, that we teach routinely. All the basic stuff there. We don't do fetal monitoring, but everything else we pretty much do. We do IV certification. We put in PICC lines, all these kind of things that are kind of what you're talking about in terms of teaching people to do them. And so at the student level, we don't teach residents or people postgraduate at this point now, but we pretty much do all the stuff before they get their degree.
And do you do that on the nursing level or at that EMT advanced paramedic level?
So we have a paramedic on staff, but we don't teach paramedics. We do RNs, MAs, NPs, PAs, and DOs, and actually one MD so far.
Okay.
And then in terms of that's in terms of the education that we do at this point. And there was one other question.
There was the how long do you see until you could be standalone, or at least a significant reduction in the assistance?
I think that's a Queenie question.
Spoken like a true dog.
Now, according to the last 2 years, now I don't know if that would count. This was with CNRC. The average they were seeing on a monthly basis, it was between 320 to 360 patients. That was when it was good, then when you had the actual provider, not the drunken PA. It was around there, 360, 350 patients. So the reimbursement, let's just say 150 per patient. This is on an urgent care level. That's just an average. I foresee it within the next, once we have all the licensing, maybe 6 to 8 months. Because I calculated we're looking at about close to 500,000 on reimbursement if we were seeing about 320 patients a day. I mean, 320 patients a month, and with the reimbursement of 150. I know it could be more. That's with 12 patients, open 5 days a week, 12 patients a day. Now, at one point, I know CNRC, they were seeing between 18 to 20 patients a day. So it's a matter of building that relationship. And like the provider that we're bringing, and Dr. Koka will also come out here. If they want to see an MD or a DO, we'll have an MD and a DO coming in, seeing these patients. With Brent, I think a lot of the patients here, they know him, they're familiar with him. So they'll have that comfort of knowing that it's the same provider.
Okay.
So I would say about 6 months. I don't want to underestimate. Let's just say 8 months to a year.
And you guys will have, both your groups, how about your abilities to perform that occupational health aspect? Could be huge. Got a lot of ground to cover as far as integrity goes right now with our local employers, but that could be huge. I know right now we do not have anybody DOT certified to do DOT physicals. We do not have anybody who is
You have one local in town that I have in mind that she's really good.
She is probably certified to do the DOT drug screens, but not the physical.
She is.
The medical
it expires.
portion?
Yeah, but our provider can do the medical portion of
Okay.
it. And I'm familiar with the contracts that they have. The reimbursement is actually $150 on that one. And then the regular, just a quick drug screen, we send those out. There's a chain of custody with those, so we charge like $30 for a patient to come in, and we do the administered drug screen. So that person that we're talking about, I'm not sure if she's even willing to, but our staff in Las Muted, DOT certified, and our providers.
Perfect. Respiratory fits.
Yes.
During,
You have a
Ms.
public comment
Give
as
me
well.
one second. Devin, would you answer for the DOT just before we get to? Yeah.
Sure. So we actually unmuted. One of our nurse practitioners is DOT certified. Fit tests, drug screens, the chain of custody, exactly as mentioned. That's all kind of set standard stuff. Right. Any immunizations that are required, titers, things like that, we're familiar with.
Okay. And really quickly, just because, so with your guys' plan for the federally qualified medical center, rural health clinic, and the enhanced reimbursement that you mentioned, do you forecast any higher returns on that?
I think that initially it's going to be low. I think just like Queenie said, I think 150 is a great benchmark sort of to get going. I think it could easily be more at just as she mentioned. It depends on comfort and who is coming and really the metric. So you asked like how long, right? If we consistently see the 20 patient a day, I mean, you're going to see me here in 3 months and we're going to say, hey, it's awesome. We're going fine. Here you go. We're set. It'll just how long it takes to get to that point.
And the, wow, my brain just went blank.
I think we have a public comment.
Go ahead, and hopefully I can remember what I'm thinking about.
Who do you have for public comment first?
Hello?
The speaker's been unmuted.
Yes, go ahead.
Hello? Hello?
Go ahead, we hear you.
Oh, okay, sorry. Thanks. Hey, my questions have to do more with, one, how are you organized? What kind of entity? This is to the second presenter, not Queenie's group. Second.
And this is Tom, correct?
Yes.
This is our attorney.
We're an LLC.
And then how are you employing physicians, or how do you have your physicians working for you?
Some of our physicians work directly for us. Some of our physicians are contracted through a physician group.
Okay, and how do the physicians work directly for you if you're not a professional entity?
I should say on our providers, so nurse practitioners, PA, et cetera, work for us directly. Physicians are contracted with a physician group. Yeah. Okay.
Thank you for answering that. That was perfect. And then my other thing is just a comment to the board, and what I don't hear here is any figures, any actual proposal that you can vote on at this point. I think what you need at this point is you need numbers. I mean, I think both these groups sound great, from a clinical perspective, which I'm not qualified to speak to, but just in my experience, it sounds good. But we don't have any numbers to look at. So until we know what the deal is, it's very hard I think it's going to be very hard for you to do anything. So that is my comment.
Anybody else? Tom?
Yes. Sorry, it's loud where I am. What?
Can you explain the concept we talked about this afternoon on not reimbursing but a loan system?
Yeah. One of the conversations that Don and I have talked about this a few times, and one thing I brought up was, we understand that you need time to ramp up. That is fine. And it takes time for bills to go through, 60 to 90 days for some, longer for others, God bless them. So if we need to fund you up front to keep that, to allow you to start up, then at some point when you collect that money that we paid you for to run your facility, we would expect to get some return on that so basically, if you're billing, say in month one, I know you wouldn't, but just let's pretend. Say month one, you bill out $30,000 in total bills. At the end of 90 days, you collect 20,000 from that. Well, the district would, under what we're talking about, may say, well, we want that 20,000 back, right? And that would get returned. You'd still have money coming in the next, and it would go on for as long as you're taking money from the district. That, to the extent that you get reimbursed, we would want to get that back, because presumably you're not staffing something at a loss, because you're staffing it to make a profit, or at least break even, but presumably you're business people, so you're going to make a profit. And so at some point, the district does not want people to be profiting off of the taxpayers. So how does that explain, Don, is that sufficient?
It does, and I'm going to put that question out to both groups. What are your feelings on stuff like that? I know, in the past, what we've done, and we've made mistakes. We've signed exclusive contracts with two different entities, and it was strictly putting money out to run their business. And we have that coming up right now. I've got the last group that was in here, CNRC, Van. So they're looking for reimbursement for a bunch of stuff, but they still have all kinds of billing out there. So where does that come in? Who gets that billing? Is that coming back to the hospital district, or is that just extra income that group's going to hang on to? So that's what we were talking about. How can we help, but not just give away the... Yes.
Okay, help me understand, Tom. So let's say for month one, let's just say that we're making money, we build out. You gave us 10,000, and the reimbursement that we received from insurance company is 20 grand. You want me to give the 10 back to the board, correct?
Correct.
Got it.
Well, we'll put it this way: as you get paid on things that we, so when the service was provided, if we were supplementing you at that time, that to the extent we supplemented you, we should get that money back. So because you may not collect in month 3, it might be month 4 when you collect for month 1, but you also collected part of it in month 3. So it's kind of on an ongoing basis, on a rolling basis. Does that make sense? Okay.
Yes,
Okay.
It does make sense to me, but I just don't want it to be, okay, we made 20 and then you want me to give the whole 20. So that's just like, okay, wait a minute, this doesn't make any sense. That makes sense. I get it.
And in fact, that
So for each, right.
To some degree, that's how CNRC's was actually, their contract was supposed to be, is that they would show that credit to offset their operating costs. Obviously, if you've got money coming in, okay, I've got money offsetting that loss. And that, I don't remember ever seeing that in any way.
Well, that's not really how the contract, Patty, with all due respect, that wasn't how the contract really read. I mean, I think that was maybe the intent deep down, but it was not expressed well in the document that, was provided. So that would it would be much tighter. Okay. I mean, it would be a quarterly or semi-annual true up, if you will. We'll go back through and account for everything and figure out what it is. And, and it is what it is. I mean, it's not going to be very complicated, I don't think, but it will require the input of both parties. And so I think it makes sense then to evaluate what the cost is on a monthly basis to start and say, this is what we will need to start, and make sure you understand what that is, because we expect that, obviously if you bill 20 but pay out 30 because you need to get going and you're not seeing enough patients to support yourself, understood. That's what that money would be for. But to the extent that you're making that money back later, that money should be returned, and, so that we can continue to provide services as well and meet our obligations.
Now, I'm being hopeful here. If we get to a point where we're making money, we're not being subsidized, and we profit, we keep all of that, correct?
Of course.
Absolutely.
Okay.
That's what we want.
That's what I'm
And
saying.
our goal is to assist you to get you on your feet. The ways we're talking about assisting, we have our clinic back. We're going to manage the clinic. We're going to pay all the utilities for the clinic, everything involved in that clinic building. So we're giving you a place to set up business without any overhead per se, except for your medical personnel and stuff and your staff. And we're hoping that there's enough income or enough patients to get you on your feet to where you can make it a viable business. Otherwise, why would you even be here?
I do believe it is doable with what I've seen. I've actually looked at the numbers the last 2 years from 2020 when CNRC started. I was able to look at some of the stuff that they have. It is doable once you get to that point of number of patients. And the consistency of provider, of course. I know that makes a big difference. I lived here during pandemic for close to a year, and I know what's needed, and I know what the town needs, and how to actually make it work. And having that consistency with provider and staffing makes a big difference. And the people in town that are staff and they know the people, I know that made a big difference.
So another a question to the both of you. Does this sound like a massive accounting burden for what Tom is discussing?
On our part, no.
Then it should, and then let me follow it up with the second part of that too, is then it shouldn't be too big of a deal to have your accounting separated enough that could be audited at the end of the year to verify, so that the taxpayers can see that they're getting their money's worth and they're getting their money back if needed.
That's the reason why Dr. Coca, he has so many different practices. We separated this. So it is this. If you want to look at it, you want to have Tom or an accountant look at it, it's there for everyone to look at. That's why we wanted to separate our clinic and Dr. Coca's clinic with this.
And I'm terrible at names. Devin?
I answer to most things. So it's funny, Tom, on the phone, right, attorney, I was thinking of this exact thing while I was driving up here, because I was like, well, the provider that's operating, they're subsidized. What they want to do to get off of subsidy is to get enough patients, so they want to be incentivized to get the patients, but what's the incentive for them to get off a subsidy? I was thinking of this exact thing, right? I think that the exact concept, just like I mentioned, that operating cost plus whatever that margin is that everybody can live with, I think that's the way to go. It could present some accounting challenges, but as long as we had an understanding of this is what our plan is, because some insurances pay in 2 weeks, like we mentioned, and some took us 8 months to get our first VA payment, and that was really hard because they owed us a lot. And so, sometimes it comes in like that, and that's just sort of how it goes. Sometimes you think you're going to be reimbursed this, but you're really going to be reimbursed that. Sometimes the patient has not met their deductible for the year, right, and you get nothing. And that's just sort of how it goes sometimes. So I think that transparency, putting that out there, that concept makes sense to me. I think figuring out how to, again, incentivize the provider to be on their own, self-sufficient. And the best way that I know of for us to be able to do that is to be able to offer a couple of different things. And when we can offer those different things, we get to offset costs, share things. Now our overhead goes pretty low. And just to be clear, the overhead in this is not the expensive part. It's the staff. It's the personnel. That's the expensive part. Because we can find random people, right? We'll get them to sign up. They'll come from who knows where, right? And they'll come here, right? The doc knows, it's hard to find good people, and those cost. And so to find those kind of staff, that's the tough part. And I understand exactly what you're saying. How do you get someone to not want to be subsidized? And I'm perfectly comfortable with that concept. So my brain is geared to how do we get to do this on our own and not have to ask. Now we get to do fun stuff.
You're ready to go with billing too, by the way. You don't. You already have that function going to where it'll be not a 90-day lag for your first bills.
Yeah, that's already all set. Sometimes payers are unpredictable. Sometimes they want some modifier or some code or something crazy. Usually we have it pretty well down, but we get thrown curveballs.
Fair enough.
Russell? I see you sitting there. Do you have any questions?
He looks like he has something to say.
Questions? No, I think I'm actually good. I have thoughts, but not questions yet at this point.
Okay, so just flip me a finger if you got a question so I know. Okay, so we're in a situation where we need to provide for the town and surrounding areas. Speaking of both groups, do you think there's enough revenue out here to take and support both groups?
No. I mean, I don't.
Okay, well, that's,
I think that's.
you know, and like I said, I can see the previous numbers and all that, and I have questions on if that is true numbers.
Well, I have no faith in one document that was submitted to us from the previous group. I don't have any faith in those numbers. And I think the forensic audit would show that those numbers, even their head counts, their lab, x-ray, patient numbers, none of that. I think that was all fabricated.
You have 2 public comments.
Go ahead with the first one. Okay, you're unmuted. Go ahead and come up with your comment. Who is it? Kevin?
Yeah, good evening. It's Kevin Romero with REMSA for the record. I just wanted to comment on a couple of items. One, REMSA would look forward to working with either entity that would perform the clinic services out there. I know it was mentioned in, I believe, both presentations about the integration, and we would be absolutely willing to work with those entities. I would like to mention to the board that the agenda item is a discussion and deliberation of various entities looking to provide medical services inside the clinic. So when I do start hearing about, ground ambulance services, air medical services, and things of that nature, I do want to make sure that, we're defining that this is for clinic services or backup for those types of assets, because obviously any patient transported comes at a loss to Nye County, may come to a loss of REMSA, dependent on the situation, and especially in the future when we talk cost-based reimbursement of a hospital. So I just want to mention that in the agenda, and that was all I had. But great presentations by both, and look forward to working with whomever.
Don't mute Kevin, because I got a question for you. Kevin, correct me if I'm wrong, but generally, if a provider has now barring certain city ordinances and local county ordinances, if a provider has a patient in their clinic and they, for instance, contract with one of 6 different private ambulance companies to transport that clinic, it's granted, while it would come at a loss with an already stretched system, it wouldn't hurt that system drastically or be any type of regulatory issue, correct?
No, I don't believe there's any type of regulatory issue. I think the question would come to Nye County and the impact that it would have on their finances and the volunteers within the region. Anytime that a patient, it's a lost transport for that county. I can't speak on behalf of Nye County. I was just bringing that to the board's attention. Backup services are always wonderful. But, if we're dependent on those types of transports ground and air to help subsidize the clinic themselves, I would have a little concern in that. But that was just something that I wanted to bring to the attention, especially with the fact that, listening in, I initially was under the impression that this was for medical services inside the clinic, as the agenda spoke to.
Okay. I was just confused because I do know that I think the idea was to not stress the 911 system any further than it already is, but at the same time, utilize whatever resources they had and make sure that we had, continued the care to, a 12-hour transport or even 8-hour transport down to Las Vegas and back would be kind of a long day for a volunteer service if they had arranged a accepting physician down south. So, okay.
Yeah, and Tim, I would just say, working together to create the right system, is very important, because everything that you're stating is true. There can be an impact to the service, the 911 providers. There can be an impact to the clinic by taking their providers out to do an ambulance transport, or an impact to the clinic if they're utilizing them for flight transport. I mean, everything comes with an impact. So I think having an understanding that whatever we do here needs to be done as a healthcare system as a whole that doesn't benefit one entity but benefits the healthcare system as a whole. And I think that is the intention of both the people presenting today and, as of REMSA as well. So I would just add that.
Thank you for your comment and advice. Appreciate it.
Okay, who else we got next? Okay, Tom, you're up.
Oh, I'm sorry. I think I pushed it, and I've come up so many times. I just kept pushing it, so I didn't really have anything. I just think that where you're at now is, I don't think you have enough information to make a decision, to be honest. You need numbers before you can decide, and you need hard proposals, not just, we think it'll be this. It needs to be in writing. It needs to be a commitment as what we can do it for this. And, I think both candidates are good. I think both candidates would provide good service. No doubt there. But I think to make a good decision, you need firm commitments and timelines and things like that, not just we think it could be this. So those are my 2 cents.
Okay, thank you. In the audience, any questions?
Horace Carlisle, C-A-R-L-Y-L-E. Boy, if I was involved in this, I wouldn't really question the structure that's been mentioned by the attorney. If as a business person, right now we have a bill from CNRC or whatever for $300,000, whether you object to it or not. They haven't operated at a profit since they've been there. So let's say they would basically owe right now, if you looked at it, $700,000. Then what happens when they turn a profit? What are you going to take the total profit that they make? What percentage out of their net positive profit per month would you take to pay back $700,000? Any businessman that doesn't build up a reserve based on profit is a fool and will not exist. This thing, we're going to break even and make money or minimize our risk. This is not business.
Okay. And I think what Tom was stating too is, if we go that route where we're loaning money to get on your feet and then you pay it back, the amount you pay back and the time frame would be something we'd have to negotiate, because we don't want to ask you to give us all this money back, because we're not in it to make profit. We're in it to get providers up on their feet and to be able to provide for us. Go ahead. Devin.
I bet I could speak for both parties, but I'm all about the formal proposal idea with the numbers. My request would just be something in writing that says what we are proposing, right? So like, what is the specific thing that we are answering to, and that will allow us to structure our response accordingly.
Okay. Questions? Where do we head from here? Do we come up with a list of what we want or what we expect?
I would say probably, and I think, correct me if I'm wrong, but I think we can take these two and pick out the apples and the apples and put them into, not necessarily make it an RFP, but put it into a
RFP, look-alike documents.
A pseudo RFP that they could sit there and go, okay, here's this, and this is what that costs.
I agree. I think we can compare their apples to their apples, not their oranges. So if they have oranges, those are out. Those are bonus later. But that would give us the formulation of that document that says, okay, this is what we want to look at the numbers. This is what we want to see how you're going to make it work. And that way it is clear. As we go into deciding and making a contract, then we will know exactly.
Hello? I'm not able to hear. I'm disconnected for some reason.
We're just on hold for a moment.
Oh, okay. Yes, I thought, I want to hear what's going on.
Yeah, they just took a break because the system went down for a moment.
Okay, well, great. And that makes me feel better for sure. Thank you.
I'm back now.
Thanks, Russell.
Motive.
Okay, let's back in session with our meeting of the Northern Lake County Hospital District. So I think where we're at is we're going to go through the proposals. We're going to come up with a sheet of what we really feel our bottom line is that we need you to provide. We're going to get that to you guys, and then what's a sufficient amount of time for you to look at that and come up with proposals back?
Dollar proposal. Put that on. Dollar proposals.
Because
2 weeks.
3 to 5 days.
3 to 5. Wow. Okay.
Okay, because we have a meeting every 2 weeks. Our next meeting is July what?
7th.
The first Thursday in July, the 7th. That's our next meeting is July 7th, and then it'll be the 21st after that. So
3 to 5 days. Okay.
even though we tried to, we talked about getting everything staffed as soon as possible, we need to make the correct decision here so that we can live with it.
That sounds so horrible.
Well, we also want to be cautious in how we go in it with the money and having that written out clear, and the reports back to us written out clear. We are in a rush to get someone in there, but we can't let that outweigh our common sense and be a little bit more purposeful than just throwing money at a problem hoping it'll go away. And that's what I'm afraid we're trying to do right now. So.
Okay, so in closing, does anybody else have anything they want to present?
Where's Carlisle? Carlyle. I'm very concerned as a observer based on the prior provider and my being at the meetings when multiple things have been said that could be defamation, can be challenged or litigated. And part of the discussion of the night when the request for payment was presented, a good part of it was not in dispute. My understanding, based on what numbers I heard were thrown out, was maybe $40,000 to $45,000. I really encourage you, because if I was Dr. Van Lee, based on what I know, I've never read the final contract. I read the initial contract, because the second contract was sort of put in a shelf in a dark room, except for the board. The point is, and that's not the issue. The issue is, I think you're giving him a basis to file suit for multiple. I mean, I'm a paranoid, and also based on my youth to training with the mafia and stuff, I'm a paranoid. I'm a jealous lawyer because that's why I'm not in federal prison. Thank you.
Okay, noted. And we are in contact with Van. I have contacted him, and I told him what we needed for documentation. He just hasn't gotten back with us with the documentation. We have not made any decision on total amount of reimbursement or a partial or anything like that. No, that was an email that I can track.
Just make sure you can provide it in case it comes up in litigation.
Absolutely. Okay, so any comments from Nancy?
No, it's going the way that I had hoped it would. As you know, that was a week ago, and my information that I had sent to you, Don. So I appreciate with our attorney getting to be here today and stating exactly what I was concerned about when I had my apprehensions about everything. So thank you. I think the presenters are both great, but I do think that we have to get some things in order before we can move forward, and that's going to be in that formal proposal for, the reoccurring bottom line and dollar figures and all of that. Thank you.
Okay, thank you, Nancy. Tom, you still on with us? You have any last statements? No, Tom? Kevin?
He's here.
Anybody from the audience?
I'd like to make a motion.
Absolutely.
I make a motion that Tim be the central point for this, that Tim work on I don't even know what to call the document, but it would be requirements for contract to provide care in the clinic, that he work with both of these groups on what our requirements are, what our reporting requirements are, all the documents that they need and information that they need so that they can prep for a formal presentation to include the services they can provide and at what cost they can provide that, and what they look like what the reimbursements would look like. Does that make sense?
Okay, I have a motion with everything that Patty said. But I can't repeat
I'll
it.
second that. I'll second.
And I have a second. Thank you, Nancy.
Tim will do a good job.
So I have a motion and a second. Any further discussion? If not, I'll call for the vote. All in favor say aye.
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 Aye. Any opposed? Okay, passes 4-0. Tim will handle this, and we will get it out to both providers, and we'll move forward with this. So we'll put this on the July 7th agenda.
Tentatively.
Tentatively right now.
Let's make sure I can get the document drawn up quick enough.
No.
Will you be getting those agenda items to me?
I will. As soon as I have the document done and I get everything back from them, it'll go on the very next agenda, whatever happens to be that date that it falls.
Right, and then when you get it out to the both individuals, can you please CC me so I can track and make sure everybody's got it?
Yes.
So we're all on the same page.
Make sure that we're all fair and it's all verified.
Okay.
And you guys know how to get a hold of Tim? Yeah, and you guys know how to get a hold of
We will here in just a minute, I promise.
Okay, so anything further? If not, I'm going to move on. See if I can read. Item number 8, general public comment. Second, do I have any other public comment? You've been sitting here quiet all day. Nothing?
Patty, did you have a time for your EMS days?
8 to 4. 8 to 4.
Okay.
Yeah. And I'll get with you, Melissa, so that you can do I want you to send out, save the dates. I'm already compiling a list of those folks of who I need you to send a save a date to. So we are early, but it'll give them time to start formulating some ideas and problem solutions, that kind of thing.
Commissioner Jabor, do you have anything? Okay. Move on to item 9, which is announcements. Second, anything?
No.
Good. Item 10, adjourn. Thank you, everyone.
For coming in and